Welcome to the lecture on somatic disorders. This is chapter 21 out of your book, key terms that the book recommends you understand for this content, learning objectives that should be met at the end of this lecture. So, introduction to somatic symptom disorder. In the early 1800s, the medical field began considering social and psychological factors in illness. The term psychosomatic was coined to describe the connection between the mind and the body in health and illness. The mind can cause physical symptoms or worsening of existing physical illnesses. Emotional stress can worsen medical conditions and can cause unrelated physical symptoms. Hysteria refers to multiple physical complaints without an organic base. The concept of hysteria dates back 4,000 years, originating in Egypt and later linked to witchcraft and evil spirits in the Middle Ages. French physicians identified hysteria as a nervous system disorder. Sigmund Freud discovered that hypnosis could relieve symptoms of hysteria by helping patients recall memories and express their emotions. Freud proposed that unexpressed emotions could manifest as physical symptoms, a process now called somatization. So this lecture will discuss somatic symptom illnesses, somatoform disorder based on concepts of somatization. Somatization is the transference of mental experience and states into bodily systems. Somatic symptom illness is physical symptoms that suggest a medical condition but lack an organic cause. Organic cause would be a physical cause. Three central features of somatic symptom illness is physical complaints suggest major medical illness but have no cause. Physiological factors and conflicts play a role in initiating, exacerbating, and maintaining symptoms. Symptoms or exaggerated health concerns are not under the client's conscious control. So, as a nurse, we should recognize that clients genuinely experience symptoms and cannot control them. Some types of somatic illnesses we have somatic symptom disorder. This is characterized by one or more physical symptoms with no organic basis, leading individuals to focus intensely on health outcomes, often believing symptoms indicate serious illness, causing significant distress and anxiety. Functional neurological symptom disorder involves unexplained, sudden sensory or motor deficits, like blindness or paralysis, which suggests a neurological disorder, but are not associated with physiological factors. Functional impairment is significant. Labella indifference is when a client has a seemingly lack of concern regarding their functional loss. Pain disorder, the primary symptom is pain, which is unrelieved by analgesics and significantly influenced by psychological factors, including onset, severity, exacerbation, and maintenance. Illness anxiety disorder is formerly hypochondrias. This is a preoccupation with fear of having or getting serious disease. Clients may misinterpret bodily sensations or functions, so persistent fear of life-threatening disease occurs. With our somatic symptom illnesses, the prevalence is more common in women than in men. It affects about 5 to 7% of the general population. Estimates vary, though. Up to 30% of primary care patients have medically unexplained symptoms, many of whom have somatic symptom illnesses. Pain is a complaint. Pain is one of the most common complaints in the medical practice, and it can really be difficult to distinguish between physical and psychological causes. So when we look at our onset and our clinical course, Somatic symptom disorder. Symptoms often begin in adolescence. Diagnosis occurs around age 25. With functional neurological symptom disorder, this most commonly appears between ages 10 and 35. With pain disorder and illness anxiety disorder, and they can occur at any age. The course of illness. All somatic symptom illnesses are chronic or recurrent, and they can last for decades. Clients with somatic disorder and functional neurological symptom disorder often seek medical help or mental health care, forgive me, only after exhausting medical options. Clients with illness anxiety disorder or pain disorder are less likely to seek mental health treatment unless they have co-occurring psychiatric condition. Health seeking behaviors. Clients frequently move from one physician to another. They might consult multiple providers simultaneously. They often feel frustrated with the medical system and may believe that their condition remains undiagnosed due to provider incompetence. Some related disorders. We have malingering. Malingering is an intentional production or exaggeration of symptoms for external gain. So your client's going to exaggerate or make symptoms to avoid work or evade legal trouble or get drugs or get money. No real symptoms or grossly exaggerated mild symptoms. Usually with malingering, symptoms stop once the person achieves their desired outcome. Factitious disorder, formerly known as Munchausen syndrome, is intentional production or feigning of symptoms to gain attention, not external rewards. May involve self-inflicted injury. Factitious disorder imposed on another, formerly known as Munchausen's by proxy, involves inflicting illness or injury on another to gain attention or praise. It is a form of abuse, common among people familiar with medical professions, often results in legal consequences. There's also a medically unexplained symptoms and functional somatic syndromes are commonly used in general medicine. They refer to physical symptoms without a clear medical diagnosis. These terms overlap with somatic symptom disorders in psychiatry. So this is something that a medical doctor will label. The patient may prefer terms like MUS because they avoid the stigma of psychosomatic labels. Effective treatment includes validation support, symptom management strategies, and good patient-provider communication. Etiology. Individuals with somatic symptom illness internalize stress, anxiety, and frustration instead of expressing them outwardly. These internalization leads to somatization, that unconscious defense mechanism where psychological distress manifests as a physical symptom. Many clients struggle to express emotions verbally and may experience inability to identify their emotions. Physical symptoms often worsen during interpersonal conflict or emotional stress. Symptoms severe psychological purpose. They say there's a primary gain, which is a relief of the emotional distress or release of the conflict. And then there's a secondary gain, which is attention, comfort, and care received from others while they're ill. Somatization is more commonly associated with women. They cite that that's due to gender norms, that men are taught to suppress complaints, women seeking medical care more frequently and are more likely seeking it openly. We do note that it's more common in children who've had sexual abuse and higher with rates of other psychiatric disorders like depression. There's some biological theories. Clients with somatoform disorder process and interpret body stimuli differently. They might have difficulties distinguishing relevant from irrelevant sensory input, which leads to amplified awareness of normal bodily sensations. So, someone who might have a minor sensation of muscle tension, GI movement, may perceive it as more intense or distressing. We also have our acute stress, which acute stress can cause a visceral hypersensitivity. We see that particularly in our GI system, increase in symptom severity. Overall, low inhibition of sensory input exaggerates physical experiences and responses. Cultural considerations. Many cultures have specific somatic expressions of psychological distresses, which may not align with Western medicine diagnosis, but are deeply rooted in cultural beliefs and idioms of the distress. Cultural variations in somatic symptoms, the type, frequency, and interpretation of the somatic symptoms vary across cultures. Some psychoneurological symptoms, such as burning in the hands, feet, sensations of worms or ants under the skin, are all common in Africa and South Asia. Reproductive related somatic symptoms are seen in India. That involves anxiety about semen loss. Some other cultural specific somatic disorders, um, Koro, that's that Koro, which I could be completely mispronouncing all of these, so forgive me. That's found in Southeast Asia, and it's a belief that the penis is shrinking into the abdomen, potentially fatal. Falling out episodes are southern US and Caribbean, which is a sudden collapse with temporary blindness or paralysis. Hwang Buyong is Korea, and it's due to suppressed anger. It includes insomnia, fatigue, panic, indigestion, aches, and pains. Sangyu Dormido is Portuguese, Cape Verde Islanders. Symptoms include pain, numbness, paralysis, seizures, even miscarriage. And Shanghai Shirao, that's the last one on the slide, is from China, and it includes physical and mental fatigue, dizziness, headaches, sleep issues, memory loss, GI problems, and sexual dysfunction. So treatment. The aim is symptom management and improving quality of life. Empathy and sensitivity are crucial to building trust. A strong provider-client relationships helps reduce clients' doctor shopping. Pharmacological treatment, depression and anxiety often accompany somatic symptom illness. So often we use SSRIs to treat the depression and anxiety. And examples of those would be your fluoxetine, sertraline, or paradoxine Paxil. Pain management. If the client's having a lot of pain, we want to refer them to chronic pain clinics. That can be helpful. We can do techniques like visual imaging, relaxation, physical therapy. We can use pharmacological, like nonsteroidal anti-inflammatory. Um, is a safer alternative. We want to avoid narcotic um, to prevent dependence. Psychotherapy and group therapies, cognitive behavioral therapy is effective, especially for our somatic symptom disorders, our illness anxiety disorders, our hypochondriacs, and clients that have depression and anxiety linked to somatization. And the benefits of that includes improved perception and expression of their emotions, right? If a lot of this is linked to us internalizing our emotions, then if we learn how to express them, we're going to have reduced symptoms. Improving the client's coping strategies, as well as reducing their distorted illness beliefs. Education-based approaches provide information and education that helps the client understand symptoms. It can be delivered via primary care sessions, internet-based resources, and books and materials. The prognosis, somatic symptom disorders are typically chronic, and they can also be very recurrent. With our functional neurological symptom disorder, this could remit within a few weeks, but it's a recurrence about 20 to 25% within a year. Somatic symptom disorder, the illness, anxiety, and pain disorder often lasts for years. Clients frequently feel they are in poor health despite all medical reassurance. So now we're going to look at our nursing process for clients with somatic illness, and we always want to start with assessment. So when we're doing our assessment, our physical health evaluations, the most important thing is to rule out any actual medical conditions. Never assume all the symptoms are psychosomatic. Ongoing vigilance is necessary. A new condition can emerge. Um, I talk about pseudo seizures here, right? Just because somebody constantly has pseudo seizures, they should still get, an occasional CAT scan because the tumor might not have been there initially, but now there could be. With history, long history of medical complaints, we're going to see numerous tests, multiple providers. The client might vocalize being angry or frustrated with the healthcare system. Remember, clients with the conversion disorders may exhibit that labile indifference, which is the lack of expected emotional reaction to the loss of some neurological function. General appearance. So kind of depends on what's going on with them, right? Maybe if they're having pain, they're going to walk slowly. Maybe if they're having some type of conversion disorder, we might have, weakness or on one side of our body or some other type of stroke-like symptoms. Um, Usually, when they start talking about what's going on, they might perk up during the assessment because they're getting focused attention. Descriptions tend to be a little dramatic, and they often lack specific details. Their mood and affect, we can have a labile mood. They could be depressed one moment, animated the next. Um, Especially when they're discussing medical crisis. They get very animated then. Emotions and symptoms descriptions tend to be exaggerated but lack those specific detail. Conversion disorder, they might have that, again, the labella indifference, where they have that lack of expected distress, right? Thought process and content. Thought process is usually organized. Content is usually centered around the somatic complaint, frequently catastrophizing, limited ability to reflect on emotional experience or interpersonal issues. Sensorium and intellectual function, they're going to be alert, they're going to be oriented, and their cognitive function should be intact. When we talk about judgment and insight, judgment may be impaired with overreaction to minor symptoms. Poor insight, firm belief that issues are entirely physical in origin. Self-concept, usually we're looking at low self-esteem, lack of confidence. Entire self-concept could revolve around physical health status, and they could have discomforts discussing personal strengths or traits. With roles and relationships, often they might be unemployed due to absenteeism or inability to work. They might have limited social life with isolation due to health anxieties or illnesses. Relationship strain occurs by persistent symptoms and lack of diagnosis acceptance. For physiological and self-care concerns, frequently they have poor nutrition, sleep disturbances, lack of exercise. Being that they doctor shop, we usually have polypharmacy with multiple medications, as well as possible misuse of medications. We should assess for withdrawal risks, especially if they're using benzos or narcotics. So after we do our assessment, we're going to go into our planning and diagnosing. We want to make sure that the client's safe. We're going to be looking at diagnoses of like ineffective coping, lack of positive social interaction, anxiety, disrupted sleep, fatigues, pains. Clients with functional neurological symptom disorder may be at risk for disuse syndrome from having pseudoneurological paralysis symptoms. So, in other words, if the client doesn't use the limb for a long time, the muscle may weaken and undergo atrophy from lack of use. So, what are we going to do? What's our nursing actions? So, health teaching, very important. We want to establish routines that promote proper nutrition, consistent sleep patterns, balance of activity and rest. We want to acknowledge the client's physical discomforts without confrontation. We want to assist the client to express their emotions. We want to educate the family about those primary and secondary gains, about rewarding well behaviors over symptom attention. We want to teach about coping strategies, emotional focus coping. So, emotion focused coping would be progressive muscle relaxation, deep breathing, guided imagery, distraction. Problem focused coping would be problem solving skills, social skills training, scheduling and prioritizing tasks, planning pleasant activities after difficult tasks. When we talk about client and family education topics, we can do mind body connections, daily structure, relaxation techniques, role play for social interaction, positive reinforcement for healthy behaviors. And then your evaluation criteria is really going to be based off of what you've implemented. Community-based care, your primary focus, we're trying to build a trusting relationship with these clients. We want to show empathy and a genuine concern. So we need to avoid being dismissive of the physical complaint. The role of the nurse in the outpatient and community settings is going to use therapeutic communication. In all the settings, she's going to support the clients in understanding that mind-body connection and acknowledge symptoms as they are real to the client. We do referral sources, so we may refer clients to pain clinics if they're having chronic pains. We may have to refer them to some type of therapist that can do cognitive behavioral therapy with them, support groups, peer networks, all of that in the community. We want to help encourage them on social engagement, help them discover activities and hobbies that they like doing, help fulfill their psychological needs, and reduce their reliance on the physical symptoms for emotional expression. Your big goals here are going to be improve overall function of quality of life, reduce the client's dependence on the healthcare visits for non-medically explained symptoms, and promote healthy outlets for emotional expression and coping. For health promotion, mental health promotion for the somatic symptom illness, emotional expression and symptom relief, common in individuals who struggle to express to express emotions, conflicts, or stress verbally. Physical symptoms often serve as substitute. Our trends, overall decline in somatic illness has occurred in recent decades. We feel that that's due to improved public education, greater self-awareness. However, we also have the internet, right, which gives clients ease of health information, but it actually acts as the double-edged sword because although it gives them the education, it has that negative effect of increasing health anxiety, especially in those that are already vulnerable. There is cyberchondria, which is like the hypochondriacs, but it's related to excessive health-related internet searches. So cyberchondria. Mm, all of this can reinforce those somatic symptom behaviors. So, key mental health promotion strategies are going to be to encourage emotional literacy and health expression, educate again on that mind body link, provide balanced and accurate health information, and help clients set boundaries about the internet use for health related topics. And then our final slide is always about self awareness issues. When we're treating clients with somatic symptom illness, managing them as a nurse can be very frustrating. Clients may be resistant to it being a psychological explanation and insist that their issues are purely physical. Initial response to referrals to mental health care services can be very angry, very hostile. They might be kind of passive aggressive. They might be very cynical. And it's really important for us as nurses to stay calm, patient, and empathetic with our clients. We want to make sure that we're setting realistic expectations. So clients have coped through with their somatization for probably many years. We know that progress is slow, it's subtle and nonlinear. So we need to repeatedly focus. Um, on physical symptoms that are expected and that's not a sign of failure. Slow and steady wins the race, right? Key nurse responses. We need to avoid arguing, avoid challenging, avoid getting in those power struggles. Make sure we're staying non-judgmental and accepting of the client, even when the complaints feel repetitive. We want to celebrate the small wins. We want to validate any emotional insight and help with coping behaviors. We want to maintain the therapeutic relationship, focus on building trust through consistency and empathy, reinforce functional improvements such as better sleep, nutrition, socialization, and acknowledge their experience of distress without reinforcing purely medical expectations. And that is the end of this lecture. Thank you.